Hi, this is Stephen, and in this video we'll continue our discussion of parameters that are useful in diastology or understanding how the heart fills. And this time let's look at mitral inflow, the flow of blood through the mitral valve into the left ventricle. And so let's turn to our apical 4-chamber view. That's our left atrium emptying via the mitral valve into the left ventricle. Over here you've got the right ventricle and your right atrium with tricuspid valve. And we want to measure the mitral inflow. And so we'll take our pulse wave Doppler and we'll measure the velocity just at the tips of the mitral valve. And what do we see? Well, we'll see a graph that looks something like this. We'll see in diastole, we'll see some early blood flow, and then we'll see some late blood flow with the atrial kick. And then in systole, you may see something down here, you may see some mitral regurg or something else, but we'll focus on diastole, where again you see the early diastolic flow, and then you see the late blood flow due to the atrial kick. Units are centimeters per second, and these are second. Now, as you may guess, in atrial fibrillation, that atrial kick may be completely messed up, but we'll say that this patient is in normal sinus rhythm, and we're looking here at, this is diastole, when the heart is filling, and then somewhere around here is systole. And you may or may not see some mitral regurgitation during the systole. Okay, so what can we learn from the different patterns of mitral inflow? Well, a healthy pattern looks something like this. It looks like a good amount of blood flow early, and then a fair bit of blood flow late. So some early and some late in diastole, something like that, like what I've drawn. And this may be, the values, let's say this is 100 centimeters per second, and let's say this one is 50. Note that this is much more, when we were talking about tissue Doppler in another video, and E prime, we were looking at values of 6, 7, 10. This is much more. It's blood flow, right? The blood flows at a much higher velocity than the tissue moves. So this would be considered a normal filling. Okay, now what if we have impaired relaxation? Impaired relaxation has the following pattern. Your E wave, and I realize I should have labeled these, so I'm actually going to up on top. We'll call this our E wave, and we'll call this our A wave. With impaired relaxation, you actually see that the E wave gets less, and it can actually be less than the A wave. So your E wave, which is less than your A wave. This is impaired relaxation. Impaired relaxation. And so in impaired relaxation, you'll note that actually, and just to be clear, let's label these on top here as well, so there's not confusion. E wave, A wave, E wave, A wave. You're actually more dependent, because your ventricle doesn't relax well, you're more dependent on that atrial kick on this guy right here to really send blood flow in. And so if these patients go into atrial fibrillation, that could be a problem, right? More blood is actually flowing into the left ventricle during that later A wave. All right, and then what's the next pattern? This is where things get confusing for many people. So the pattern looks like this. E wave is larger than A wave. E wave is larger than A wave, and this is called a pseudonormal pattern. Pseudonormal. And you may be wondering, this looks exactly like our normal pattern. And you're right. That's why it's called pseudonormal. That's why it confuses people. What's going on here? Well, if you take a step back, again, there's more blood flow going in the early phase than in the late phase. But the way I think about this normal is that here we have blood is being pulled in. You have a healthy left ventricle that is able to expand nicely. The ventricle expands and blood is pulled. It's pulled in. And that's why you have a good amount of early blood flow, and then you have some additional late blood flow in the A wave. On the other hand, I'm going to clean this up. Down here in the pseudonormal pattern, what's going on? Well, down here you actually have a push going on. Why? You have elevated pressures building up here in your left atrium. Pressures building up, building up, building up. And then as soon as the valve opens, blood gets blasted in. And the walls here are really not, I mean, this wall, I'm not going to draw arrows showing that it's nicely expanding because it's really not moving much. It's not expanding much. But you have such a buildup of pressure that the blood is pushed in. And so just looking at blood flow alone, you may get confused because the E wave is tall, the A wave is small, but it's because of a push. And we'll get into how to separate this normal versus pseudonormal in detail. But that's the reasoning for why these look the same. One is a pull, which is healthy. The other is a push of blood into the left ventricle. Let's scroll a little down. And our final pattern of the E and A waves is called restrictive filling. And in that one, you have a very tall, short E wave. And you have a A wave that's much smaller. Tall, short E wave. And this is restrictive filling. And this is really more of the same. There's this push going on and so much pressure builds up in the left atrium, as I've drawn in red, that it blasts into the left ventricle all of a sudden. The left ventricle is really not doing much. It's restrictive. It doesn't fill nicely. So these are the different mitral inflow patterns. One point that I'll make here is that if you have the patient do a Valsalva maneuver, then you can actually change from one pattern to another. And you go up in this direction. So we'll say with Valsalva. In other words, why? So Valsalva, you bear down, there's less preload, there's less blood flow, and so it makes each step, each pattern look one better. So if you start in the normal and you Valsalva, you'll stay normal. Nothing will change. It will still look like this. Let's say you are in pseudonormal though, and this is where it's very helpful. If you're in pseudonormal and you Valsalva, so there's less preload, you'll see an impaired relaxation pattern. It will look like this. That tells you that even though the E wave was higher than the A wave, you are not dealing with normal filling, you're dealing with pseudonormal filling. One other point that I'll mention, I'm just going to clean up some of that additional marking, is that it's helpful to keep in mind a cutoff right here. So in both the pseudonormal and restrictive filling patterns, we typically have elevated left ventricular filling pressures. And that's what we were talking about before. You'll remember that before, when I drew this red here in the left atrium, the reason blood blasts through is because you have elevated filling pressures, it builds up, and then all of a sudden blood is forced. As soon as the mitral valve leaflets open, a tall E wave, blood is forced into the left ventricle. It's not pulled in by a left ventricle that's expanding in a healthy manner, it's being pushed in. And so for both pseudonormal and restrictive filling patterns, those typically, we can say that there are elevated left ventricular filling pressures.